Ladies and gentlemen, good afternoon. It's my absolute pleasure to welcome you all to today's online Grand Round session from the Bariatric Department of Harlem Hospital. This event is being hosted in collaboration with Harlem Hospital and International College of Surgeons US section. Our topic for today's session is one of the significant important in the realm of modern medicine, surgical management of morbid obesity, personal experience, and outcome. As we all know, morbid obesity is not only a pervasive health issue, but also a complex condition that presents a myriad of challenges to patients and healthcare providers alike. The surgical intervention available for managing morbid obesity have evolved significantly over the years, presenting new opportunities and outcomes for those affected. Today, we are privileged to gain insight from a true pioneer in this field. Our speaker for today's session is Dr. Patricia Newman. She's a distinguished surgeon and esteemed leader in the surgical community, being the past president of the American College of Surgeons and recipient of several awards, and also a Lifetime Achievement Award at the Clinical Congress in 2019. She was made Honorary Fellow of International College of Surgeons, US section, Royal College of Physicians and Surgeons, Glasgow, Royal College of Physicians and Surgeons at Edinburgh. She is the founder member of Association of Women's Surgeons and currently Professor Emeritus at the State University of New York. Dr. Newman brings a wealth of knowledge and a unique perspective to the discussion. Her personal experience and outcome in the surgical management of morbid obesity will undoubtedly provide us with invaluable lesson and provoke thoughtful discussions. And it's my great honor to introduce two distinguished panelists who will contribute through the extensive expertise to our discussion today. First, we have Dr. George Fursley. He's a renowned surgeon and impressive career dedicated to advancing minimal invasive surgical technology. He's currently the Fellowship Director for Bariatric Advanced Minimal Invasive Surgery at NYU Langone Hospital Center. And to his great credit, he has guided several hundred fellows from his program, and I was one of them. He is also currently Medical Director of MBSQIP Accredited Center at NYU Brooklyn Hospital. Dr. Fursley is highly respected for his groundbreaking work in the laparoscopic surgery, having performed the first laparoscopy nephrectomy in the country, and his commitment to the improving patient care. His wealth of experience and innovation approach has made significant impact in the field of bariatric surgery. Dr. Fursley's insight into the latest development and his hand of experience will provide a valuable perspective in the surgical management of morbid obesity. Joining Dr. George Fursley in the panel is Dr. George Fielding. Dr. Fielding is a professor of surgery at NYU Langone Medical Center. He is a leading authority of bariatric surgery and has been instrumental in developing and refining gastric band and other surgical techniques that has transformed the treatment landscape for morbid obesity. His research and clinical practice has earned him international recognition, and his dedication to his patients and field of surgery is truly commendable. Dr. Fielding contributes to our discussion will undoubtedly enhance our understanding of the complexity and success in managing morbid obesity surgery. So, truly, we are incredibly fortunate to have the esteemed professional who's joining us today. Thank you. And now I hand over the session to our keynote speaker, Dr. Newman. The floor is yours.
Thank you very much. It's really an honor and a privilege to be here. It was a result of our discussion at the International College of Surgery US chapter meeting that this presentation came about. I actually finished my surgical residency in 1970 prior to bariatric surgery. And so it was with interest that I've watched the development of bariatric surgery and have had some experience with this. But my disclosure is I have no financial disclosures, but I am not and never have been a bariatric surgeon. Actually, when bariatric surgery began, I was asked by my chair to do it as we did not have a bariatric surgeon. And it's one of the few things that I ever refused to do for the chair, but I refused. And so why did I refuse? Well, as you can see by the little picture on the left, I was a chubby kid. I was chubby from the time I can remember. I wore chubby clothes. I always was had a problem with my weight. I always fought obesity. And although I knew that it wasn't just willpower, because I actually went on diets with colleagues, they lost weight, I gained weight. But I do know that it is certainly partly willpower, and that the only reason that I was not morbidly obese was because I had to curb my natural instinct to eat everything in sight. So it was very hard for me to think that I could be empathetic with the morbidly obese. I also have always hated the idea that your image, what you look like, should influence what people think of you. I just don't like that. I never liked the beauty queen idea. I never liked having to worry specifically about having the most up-to-date clothes and on and on. So it was hard for me to relate to people who were worried about their obesity because of their body image, not because of their health concerns and their health and well-being. So I figured out that it was easier not to learn how to do it than to learn how to do it and have to be faced with dealing with something that I wasn't sure that I could do well or that I would really be invested in. But I was certainly curious. I had watched, we had a metabolic unit, and we would put very obese patients in the metabolic unit and diet them until they lost weight. And believe me, if you eat nothing, you do lose weight. And so these people who tell you that they eat nothing and only drink water and still gain weight are not really being honest with themselves. So I was curious about this, and I watched the good and the bad of obesity surgery and bariatric surgery develop over many, many years, starting with the GI bypass and leading on now to even minimally invasive gastric bypass and medical management of obesity. So it was interesting. The really good thing was for these seriously morbidly obese people who had overwhelming health issues, couldn't get around, couldn't leave their house, couldn't do sort of the normal things of life, they did effectively lose weight. It did improve their metabolic syndrome. There was no question about it. And it really changed these people's lives because instead of being housebound and really limited in all of their activity, they could again be part of society and have a meaningful life. From the surgical standpoint, there were a lot of bad things that happened early. Number one, in the beginning of bariatric surgery, the facilities were really not ready for morbidly obese patients. I can remember chairs breaking. I can remember problems with people getting stuck in scanners, people getting stuck in bathrooms, the toilets falling off the wall because they were suspended instead of stationary on the floor, and they weren't meant to hold morbidly obese patients. It was really unpleasant, and it was humiliating for these people who were trying to get help. And it was really difficult and challenging for the doctors caring for them and the nurses on the units. So that was really problematic. The patients in the beginning got very ill often. They had diarrhea, they had uncontrolled problems with their eating. They would get dehydrated. They got vitamin deficiencies. There were many, many things that happened. Pulmonary emboli, one of our own staff actually died from a pulmonary embolus in the ER where he had always worked. Very traumatic for the staff. So these things happen. The technical training was very unregulated in the beginning, and there were high complication rates. And it was really a significant risk for these people to undergo bariatric surgery at that time. The preoperative assessments, although there had been a great deal of work done on this, it was not really prescribed that everybody go through the same program. And some people had a good evaluation and were ready for the operation, and other people really didn't and weren't ready for it. So that was some of the bad for from the patient's perspective as well. Some of them were really not ready for the effect of surgery. They really still thought that they could eat kind of the way they did before, maybe not as much, but sort of the same way. And it just really wasn't true. And with the GI bypass, they may be able to eat it, but then there were real problems with them getting diarrhea and dehydrated, etc. It changed their relationships with people. It was sometimes interesting to understand that it was the imbalance between the couple of one couple being morbidly obese and the other not, that kept their relationship good. And that when all of a sudden that changed, their relationship changed. And I saw a number of people end up divorced and having troubles with their relationships that you would not have expected. And it was not always the obese person that was having the problem with the relationship. The other thing that happened was that they weren't prepared for their new body image. This excessive amount of skin under their arms, their panniculus, their legs were problematic for them, not only cosmetically, but even particularly in their groin areas. It was not easy for them to keep themselves clean. And many of the procedures that were available and really very good were not covered by insurance. And so the patients had to deal with this problem on their own. There was a significant incidence of soiling and public embarrassment from that. Poor Al Roker, I don't think, ever lived down his episode. And so those were things that happened to patients that were really not very good. And despite their appreciation of their weight loss, they sometimes had serious problems because of these other things. But then things changed. Slowly but steadily, things improved. And we learned a number of good lessons from the development of bariatric surgery. Number one, there was ultimately the certification of bariatric programs to be sure that a patient could be guaranteed that if they had bariatric surgery in one of these centers, that they would have good doctors, good support staff, that they would go through the right procedures, that they would be treated well, that the facility was ready for them, that the surgeons were properly trained, and it made a dramatic difference. The quality assurance data, which had been accumulated for long periods of time, showed a slow but steady improvement in bariatric surgical outcomes, and the morbidity and the mortality rate dramatically fell. I can remember in the beginning, it was not uncommon for people to be in the hospital for long periods of time. They had several different types of complications. I can remember even people having their GI tract rearranged so that it was a circle. That certainly was not very helpful to them. So this improvement in the quality assurance and in the proper training of physicians, and Dr. Frilizzi certainly was one of the pioneers who trained many, many surgeons in the early days of bariatric surgery, but these were critically important. And surgeons actually began to specialize in bariatric surgery, which also made a difference. Facilities address the physical needs of the morbidly obese. We all of a sudden had large wheelchairs. We had seats that accommodated the bariatric patient. The scanners actually could take a morbidly obese patient and scan them adequately. The OR tables were larger and held patients at a higher weight. The beds were made more appropriate, and actually over beds, often there were Hoyer lifts that would facilitate the moving of these morbidly obese patients so that the staff didn't hurt themselves. And the good outcome of that was not only did the morbidly obese patients who were undergoing bariatric surgery benefit, but all morbidly obese patients benefited. You would see patients who had actually been turned down for elective surgical procedures because they were morbidly obese, not because their morbid obesity had made them such high surgical risk, but just because of the physical challenges of operating on these people had been declined. And now they were being accepted for surgery. I actually did a parathyroidectomy on a 600-pound man that I think in days past might have been rejected. And I certainly know that before the onset of bariatric surgery in our hospital, I would have been very worried about the anesthesiologist caring for this patient. I would have been very worried about the nurse's safety, whereas it was just another day and another very big patient. We also saw the onset of good randomized clinical trials to determine what was the best procedure. In the beginning, there were procedures. I remember people doing what was called the angel chick prosthesis, and sometimes visualizing those through the endoscope when they were having problems with their stomach. Not necessarily a good thing. And as the GI bypass, although it was effective at weight loss, had tremendous number of metabolic problems. Whereas the onset of the gastric procedures actually showed that there were fewer complications, the patients tolerated them better, and the outcomes were better. So that these randomized trials have led to a better understanding not only of morbid obesity, but also what is the best for the patient so that they have the least disruption of their life and their well-being and have the best outcomes with good weight loss. The other thing that happened was that it became really a scientific field of investigation. And there was data that was gathered on these patients that compared their outcomes to lifestyle modification. And lo and behold, we found out that lifestyle modification was not that successful, something that most people had known for a long time. Certainly those of us who had been on diet after diet realized that this was not a very effective way at controlling particularly massive obesity. Maybe good for 5 or 10 pounds, but not for 50 or 100. So these things really helped. And this data was beneficial in so many ways. Certainly, we learned that surgery was far more effective than lifestyle modification. The data showed that surgery was durable, that once you had one of these procedures done, that not only did you achieve very significant weight loss, but that there was a very, very low incidence of developing morbid obesity ever again. And that even the regain rate after surgery, although it was present, was relatively low and tolerable and acceptable to the patients. There was far better understanding of the benefits of bariatric surgery, of who it would benefit and who it does not necessarily benefit, and who it provides actually serious psychological and emotional problems for that maybe should not undergo the surgery. There actually became data that showed that the metabolic changes improve survival, that we didn't just improve the numbers, we actually reduced the person's morbidity and mortality and improve their long-term survival. It's interesting that it really has never gone back to that of a person who had always maintained a normal body weight, but it did dramatically improve. The other thing that happened through that period of time is that there was a scientific explanation for many of the things that we observed, why central obesity may be worse than generalized obesity, what difference it makes if you have leg fat versus thin legs in a fat body. Some of these things that were previously kind of just seen but not known. The surgical complications became so low that bariatric surgery is in many places an outpatient or a one-day stay procedure, that people's lives are disrupted very minimally, and that they can adjust to their new status very, very well and very easily. And there has been a far greater of the understanding of the physiology of obesity, of the hormonal control of obesity, of many aspects of obesity that I don't think would have come to pass without bariatric surgery, frankly. And the other thing that I think was very important is it is applicable to the young, particularly women who are going to have children later, can undergo bariatric surgery, can actually improve their fertility by reducing their weight, and can go through a pregnancy without significant complications. Whereas if they had not done that, they may not have ever become pregnant, and they may have had greater challenges in pregnancy. And just to mention the current state, if they were considering taking medication for modification of their weight, it's not acceptable to do that during pregnancy. So these things were all very, very important benefits from the data that was accumulated following the development of bariatric surgery. I think now the big question to me is, will medical therapy make bariatric surgery obsolete? Certainly, the GLP-1 agonists successfully reduce weight in most people, but not all. Interestingly enough, diabetics benefit the least from medical management of their obesity. It's costly. Some states are now providing coverage for this through their Medicaid programs. Most are not. The costs range usually somewhere around $1,500 to $2,000 a month for the medication. And it's not durable. If you discontinue, it's already been shown that if you discontinue medical therapy, you will regain the weight. I think, though, one of the fascinating things about the medical therapy is how, particularly with Wegovy and with Ozempic, it's been shown that it may well improve your or reduce your addiction to alcohol, to a variety of things, because it changes your brain and the way you think. A couple of my friends who are taking this for obesity have told me for the first time in their life, they don't spend essentially their whole day thinking about food, about what their next meal is going to be, what they're going to eat, oh, how good it would taste to have this. And when they start something, they can actually have 4 potato chips, not 2 bags. So I think these are interesting things about the drug treatment of obesity that we will have to learn more about. These drugs do have significant complications, however, pancreatitis being one of the most common and can be certainly devastating. So I think the answer is medical therapy will not replace bariatric surgery yet. But I do think that there are things to worry about. Number one, if I were a young surgeon, I would be really careful not to be a one-trick pony. Operations disappear. Through my time as a surgeon, I've seen ulcer surgery essentially disappear with the advent of the proton pump inhibitors and the H2 blockers, et cetera. I've seen the surgery of the lung for tuberculosis disappear with good treatment of tuberculosis, good medical treatment. We used to do staging laparotomies for Hodgkin's disease, and then the CT scanner and MRIs, et cetera, have done away with that. There are many operations that disappear. So be concerned. This could be one of them. and make sure that you have something else in your tool bag that you can certainly continue to be an active, productive surgeon. The other thing is that in general, medical therapy is more appealing to patients than surgery. And so as medical therapy improves, I think that you're going to find people who will choose it, even with the understanding that it will be lifelong therapy, that it may give them a potential complication. The other thing that I think that one has to be a little bit concerned about is with the better understanding of the neuroendocrine pathways, the pharmacology industry is going to develop drugs that are better and better and better, and that this will make them more appealing and more useful in the management of obesity. And with the newer information on the role of the autonomic nervous system in obesity, this will open avenues for yet even different both medical and surgical intervention. So I think these should be on your radar screen to be concerned about and think about as a bariatric surgeon. And then as I look at this and think about this, and I'll be very interested in hearing the discussants' views on some of these issues, should surgery be done sooner? I think that there is now so much data about the trajectory of obesity and looking at people as they become more and more obese, knowing that the handwriting is on the wall and they are going to be morbidly obese. So why let them become morbidly obese? Why not intervene sooner so that they don't get all of the bone and joint problems that they get as they get heavier and heavier, and even the worsening of their metabolic syndrome? I find that the literature on fatty liver and how this develops into end-stage liver disease with the focal fibrosis and inflammation that can be benefited by weight reduction is another thing that needs to be better understood and better looked at, and may be a new area for bariatric surgeons rather than just the weight loss for the other problems of metabolic syndrome. I think that with better patient assessment, we can understand better the patients who will benefit most and the least from surgery, and have better conversations with them so that we don't have disappointed patients, and it makes our lives much better and much simpler. I also question whether the best surgical procedure has yet been determined. I'm fascinated by the peroral surgical procedures and how they seem to be able to be reducing the gastric volume and maybe similar to gastric sleeve. I wonder if that will replace some of our current technical procedures. And the other thing that I think has not been fully really evaluated or considered is, what is the role of bariatric surgery in the disabled population? I have lived with disabled people in my family my whole life, and it is very difficult for them to maintain a normal weight. And in my patient care, I have seen many, many morbidly obese disabled people who have really had tremendous problems with their care. And I don't think that bariatric surgery may be offered to them as appropriately as perhaps it could be. So, in conclusion, if I were asked today to do bariatric surgery by the chair, would I say yes or would I say no? I'm not sure, but I'd probably be far more interested in pursuing it than I was when I was initially asked. So thank you very much for indulging me in these reminiscences. Maybe my head is literally in the clouds in this area, but I do think that it is a fascinating field, and I do think that it is really important for all of us to consider the future of our field, not only the present. Thank you.
Thank you, Dr. Newman, for your enlightening discussion on this topic. And I'm going to bring all the panelists, Dr. George Frisley and Dr. George Fielding. Thank you, Dr. Fielding, for coming on board from the SMBS. He's in the SMBS right now with the talk from Dr. Nguyen Kurian here. So I've got a lot of people watching this program and a lot of enlightening discussions coming up right now with all the young trainees and fellows also. We all know that I personally did a fellowship in bariatric surgery. And at that time, when Dr. Newman and Dr. Frisley and Dr. Fielding was there was no fellowship. So, being a bariatric surgeon, my question goes to Dr. Fielding is that what made you to be a bariatric surgeon? This is the most common question people are asking. And how did you train yourself? Because there was no fellowship training at that time, and there was less bariatric surgeons on board. So, what made you right now? We have a lot of videos, we have a lot of groups online, Facebook groups, and so we get a lot of information there. But at that time, uh, what prompted you and how you become a bariatric surgeon?
Well, I think it was just a desire to help obese people. I was obese myself, which I'll touch on later, and I was um, very early into laparoscopic surgery. So I started doing laparoscopic bypasses, sort of 93, 94, and then Paul O'Brien brought the lap band, to Australia basically, and he invited me down, and I watched him do bands. So I started doing bands as well, and it was just so satisfying to see, the help that this gave patients. Particularly doing it laparoscopically was a huge difference to, the great big midline incisions, that were done when I was a resident in the few cases that I saw. So I was already doing a lot of advanced laparoscopy by then, and so I just took it on board. I was, I was basically a general surgeon with an interest in HPB. Um, so I kept that going, but then started building up the bariatric surgery. And I think the biggest change for me came in 1999, when I developed a lot of health issues. And I went down to Melbourne and saw Paul O'Brien and had my own lap band, which I still have, 25 years later. But having been obese myself, I mean, I lost 60 to 80 pounds 5 times before I had the surgery over the years, and all this diet and exercise stuff. It's important, but in the fight against true morbid obesity, it's just doesn't work long term. And I knew that personally. So I had the band, and it just drove uh, my, and I still have it. I still love the concept of doing bariatric surgery, and a lot of the stuff that Dr. Newman was talking about, what I saw when I was a in the 80s, and it was hard going. The surgery was very painful and putting up with a lot of problems. So I think the biggest change, I think, was the introduction of laparoscopy. I think that transformed everything.
Thank you, Dr. Fielding. So I'd like to go to Dr. George firstly. What made
Can
you?
I ask a question of Dr. Fielding first?
Yes, please go ahead, Dr.
Dr. Fielding, if when you were young and you realized that you were becoming morbidly obese, if the technology that exists today to do bariatric surgery had it existed then, would you wish that you had had bariatric surgery when you were younger and less obese?
Absolutely, absolutely. I mean, I'm blessed. I mean, I was bright. I was successful. Even young, I was
Right.
bright and successful, and that allowed me to override a lot of the stuff that a lot of obese people have to put up with because
Mhm.
they're perhaps not quite so bright, not quite so successful. and that gave me the ego to sort of keep going despite the obesity. But eventually, what drove me is what I think drives a lot of men to surgery was I started getting really sick.
Yes.
And but if it's the issue is that when I was younger, it was just all open surgery.
Right. Yes. But I think where we
But
are
I think the
today,
fact
maybe we're not offering it early enough.
I agree, 100%. And
Yeah.
I think given the severity of this problem worldwide, the fact that the sort of numeric cutoffs to get the surgery are so high, I
Yeah.
think it's ridiculous. And you know, the disease of obesity causes so many other diseases, and I think if the guidelines were lowered, I think it would be massively beneficial to the as well as to the individual.
Does the Bariatric Society have an political advocacy arm? And if so, should that maybe be one of its major efforts, is to change the requirements so that people can benefit from it earlier? My own thought is that you have so much data and now in large data sets that you know the trajectory of obesity and you know when people are falling off the curve and you know when they're going to become morbidly obese. Why let it happen?
I absolutely agree. And the ASMBS, which is the organization, this is where I am today at this meeting, they feel exactly the same way that you and I do. But they have political advocacy groups. They're also linked with the AMA, who we all feel the same way. It's just getting the insurance to agree. That's the issue.
Thank you, Dr. Fielding. I will pass on that to George. Firstly, what prompted you to be a bariatric surgeon? And
Okay, actually, we started laparoscopy exactly as the Fielding just mentioned in 1989-90, and we started doing very advanced laparoscopic procedure, not only in general surgery. At the time, we did GYN, we did hysterectomies, nephrectomies, prostatectomies as a general surgeon, and laparoscopy. So in 1995, I started the laparoscopic fellowship. Actually, there were a few of us, 6 or 7 in the United States, that's established the fellowship in invasive surgery. And that's the Fellowship Council, which is still present till now. In 1997, like Dr. Newman mentioned, bariatric surgery was being done open with a lot of complications and not, abdominal wall hernias, splenectomies, gastrectomies, bleeding. So in 1996-97 was the first EEA number 21, if you want, that was introduced to the market. And at the time, the fellows, we started doing it. Actually, we did about a dozen of them. And I felt the same way at the same time what Dr. Newman felt, that this may not be the right thing for the patient. We did retrocolic, and we were going 15 centimeters from the ligament of Treitz to make the anastomosis reach, and so forth. So we basically dropped it until 2000. 2000 was just before when the lap band, like Dr. Fielding mentioned, was introduced in the United States in 2001, actually September 11, around that time. And that's when my fellows at the time, one of them is in Atlanta, one of them is in Jacksonville, Florida, they wanted to really do it. So we really started adding the bariatric surgery to the fellowship and minimally invasive surgery. And then after that, obviously, everything progressed to where we are right now, like you mentioned before, MDSQIP, certified center, safety, security, follow-up, testing, indication, the whole thing.
thank you. Another burning question, Dr. Newman was also there when I was debating about anti-obesity medications. There was a huge debate, and our census has gone down significantly in terms of the referral. So, what the future stance anti-obesity will enhance bariatric surgery and is going to drop the bariatric surgery. I will start from the American College of Surgery thoughts from Dr. Newman, and then I'll go for Dr. Fielding, Dr. George Fursley, where we are now and what the future lies for bariatric surgery.
From my perspective, I think it's a field to be watched closely. As I said, people generally tend to like medicine better than to take medicine better than to have an operation. But I think that there is a lot of evidence that the surgical procedures actually give long-term benefit, and it doesn't take you long for the cost of the medicine to outstrip the cost of having a surgical procedure. But I think you need to analyze that carefully, put the data out there. I think you need to plead your case to a certain extent with insurers as to the benefits of surgery versus medicine. I think you really need to look into these peroral surgical procedures to see whether they may not be just as good and have kind of an advantage of almost being non-surgical, but also better, more effective and long-term for the patient. So I think it's something to watch carefully. I heard one of my former residents do a presentation on the physiology of obesity and some of the new data about the autonomic nervous system and the vagus and on and on. And I think that is another area of medical therapy that you're going to have to watch, because it is going to challenge patients as to whether they would rather have medicine versus an operation. I don't think it's there yet, but I do think it's a real threat.
Okay, if I may give you at least the most recent, because we're in the midst of it. So basically, the volume of bariatric surgery, in answer to your question, Dr. Nazir, has dropped. And this was very highly mentioned at the Racing Sages meeting in Cleveland Clinic. Second of all, I see it from my fellows. I have a fellow in Tampa who now just gives Ozempic injections. He stopped operating. I have another fellow in New Jersey who just turned into the cosmetic aspect of bariatric surgery. So basically, it's having significant impact. It depends on the regional where you're operating as to whether you're using the GLP-1 agonist. Now, at least in my area, I can tell you that my patients, I divide them into 1/3, 1/3, 1/3. 1/3, they don't get approval by the insurance. They cannot afford it. So they still are having the surgery. And another area, community that is very affluent, whether they get approved or not by the insurance, they are purchasing it at the cost of $500 to $800 per month. And we're seeing the volume dropping drastically, no matter what the operation is. And then we have the 1/3 who take the medication, they do well. And if you want, some of them, they do develop side effects to the medication, as Dr. Newman mentioned. So that brings them back to the other methodology, one of them, which is surgery, basically. So this is, if you want, a brief thing that I see. I mean, I'm witnessing almost every day. I mean, for people like Dr. Newman, you should not have only one hat in your hand. You should be, varied, because indeed, I have a fellow in Baylor actually who, over the weekend, is describing bariatric surgery going through a phase like open heart surgery, when there is no more cabbage, and the interventional radiologist came in with the, with the stenting and the
Right.
dilatation, and they are very worried because they are not having volume anymore.
Dr. Fielding, what is your thoughts? Where we are, we are going to go in the future?
Yeah, so my feeling about this is one of the benefits of the medicine is it shows people that the obesity is due to something physiologic rather than something to do with individual weakness. And I think what we've seen with the medicines is that eventually the patients reach like a plateau where it just doesn't keep working eventually. And so we've seen quite a few patients who've been on the medicine, done reasonably well, but then it just stopped working. And the other thing, as Dr. Newman, I think, said, the minute you stop these medicines, you regain the weight, and it just shows people that it's physiologic. And I think we've seen a drop in numbers too, like everyone. But I think it's not going to be super long term. I'm more concerned about what Dr. Newman said about all these different new physiologic sort of modulators that they're going to come. But the issue is for the average Joe, these drugs are just too expensive, at the moment. But I think that will change as well. So what we use the medicines for in the surgical side of our practice is to manage weight regain, particularly after sleep, and which we see, in about a third of the patients. So it's been a great boost for those people, particularly when we start seeing the sort of trajectory of starting to get weight regain. That's when I like using them to stop it in its tracks almost. So I think just ignoring the benefits of these medicines is silly, because they do help people. I think also what's silly is how expensive they are in this country. I just think it's nonsense.
Do you think that they have a role in maybe preoperative management of the morbidly obese to make them better surgical candidates, or to temporize them through potentially crises that relate to their health, and when they're morbidly obese, that maybe they can lose some weight on the medication and then be a better surgical candidate for long-term durable weight loss? That appeals to me a little bit.
Yeah, I agree. I think there's no doubt that the way this sort of care is moving is towards this combination of stuff. And I think that, if you can get it preoperatively, say you're 400 pounds, right? And you can get this medicine and you can lose 50 pounds, and then you do your liquid diet and lose more.
Yeah.
I think doing surgery on someone who's 320 or 330 is a very different ballgame to doing surgery on someone who's 400 or 450. We see a lot of that, really
Yeah.
do. And at the moment, what we've got access to is having them do a liquid diet for 2 or 3 weeks, and hopefully they'll always lose some. But I think your point's very well made. That you could use this to enhance, preoperative weight loss. But right now, the chances of getting that, particularly if you're not diabetic, the chances of getting those medicines are slim at best.
It's getting better, and actually I've followed this for some of my patients who are interested in the medication and think that I'm smarter than they are at knowing whether Medicare pays for it or not. I'm not. I just follow the literature. But like Rhode Island has now approved it for Medicaid, which I thought was ginormous change. And so and now there is talk about approving it for addiction, for alcoholism, and other things. So, and I hope that will put the costs down, because it is very expensive.
So
I agree.
I'd like to mention before I move to another one. Recently, I was coming across an article which through the Pharmaceutical Journal, and they given the patients 1,500 patients given this anti-obesity medications, and only 6.8% picked that medications. So there are a lot of barriers. Even if you write the medications, doesn't mean that patient is going to get it, because Medicaid is the covers. Medicare does not cover this anti-obesity medication. A lot of
Right. Nope.
and a lot of commercial insurance only covering 50% of them.
Right.
So and you must be aware, at Fen Clinic, which was there in 1997, which became very popular, and then every nook and corner they had these offices built up, and people
Right.
were getting these medications, and then 10 millions of people were using this one, and suddenly after 10 years of this medication, and then studies came up with all this association with heart diseases and valvular diseases, and then all of a sudden stopped. So we don't know right now with Ozempic what is going to happen in future. So that's because I heard came across that it also changes the personality because it
Right.
decreases the dopamine effect, and people are getting more suicidal, more depressed because all this joyous activities has been diminished by taking anti-obesity medications.
I mean, Dr. Nazir, I think that we should go back a little bit to the fundamentals. Obesity is a disease. Unless we
It is.
recognize that obesity is a disease, like diabetes, like hypertension, like hyperlipidemia, because it's not just about the adults that will need surgery versus GLP-1 versus other medication on board. We have the adolescent, we have the infants, we have the pregnant women that are obese, we have the childhood, and those are a major societal problem. And then the other thing that we keep talking about obesity and the metabolic syndrome. Quite honestly, I am really sometimes shocked as to how every publication has documented that there are 13 malignancies, including breast cancer, recently published, including ovarian cancer, pancreatic cancer. 13 of them that are documented academically with level one, some of them evidence, whether it's kidney, pancreas, related directly to obesity. And yet we're only focusing on the obesity in terms of diabetes, which is fine. I mean, I'm not disputing this, don't get me wrong, but I want the public somehow to realize that the bad thing about obesity and having the surgery for obesity perhaps is to address also the meningioma, the Hodgkin, the other malignancies that are directly related. This is missing in the picture. I mean, it's amazing how the media can divert one thing and that totally neglect another thing, which is crucial. I mean, we know about hepatic steatosis, fine, and other things. So I just want to highlight this if anybody is listening out there, that there is another benefit to losing weight, whether it's by surgery or other methods. Thank you.
That's why I think it's so terrible that we allow people to become morbidly obese when there is a way to prevent it. I mean, it really, to me, is very, very annoying. We spend fortunes worth of money on so many other preventive health aspects, and we don't let pre-diabetics become diabetic. We don't, without some intervention, we don't let people with minimally invasive breast cancer develop invasive breast cancer and wait. So why do we let the obese become morbidly obese without an intervention? I just doesn't make any sense to me.
There's a huge societal bias against the obese,
There is.
and there's this still bewildering notion that um, eating a little bit less and doing some exercise is going to get rid of 100 pounds.
It's not.
And
And
it's just absolute nonsense. And but it's so deeply based in society that that, that obesity is due to an individual's personal weakness
yeah,
rather than physiologic problem. And the media drives up the wazoo. And I mean, if you look at the sort of derision that the media has given to people who want to take Ozempic, because they should be able to do it the old-fashioned way, which we all know, everyone knows it's BS, and it doesn't work. And yet the media drive, and because that, all that perception is that held by non-obese people. The
but
reality,
you also, don't you think it's also that we've become such an anti-intellectual society and that facts and data don't seem to matter anymore? There's
yeah,
so much data that lifestyle changes really don't modify this well at all. As I
but
say,
it
it
does.
may make a little difference, but it doesn't, willpower may make some difference, but it doesn't change the morbidly obese into a normal sized person.
1,000% correct. And it's just I still think it just deeply boils down to a derision held by non-obese people for obese people. And I think that's what governs a lot of this. If you need to lose 5 pounds so you look good in your bikini in summer at the beach, you can do that. But if you need to lose 125 pounds, You can't. But the skinny people basically believe you should be able to because they can.
Right. Yes.
And I think it's the root cause of a lot of this.
Okay, thank you very much. So we have only 5 more minutes left over and a few more questions coming up. And we agree that the medicine is not going to take over our bariatric surgeries. That's fine. And the other important questions, like a lot of young guys are getting trained with the robotic platform. So I will ask the two bariatric surgeons, how do you envision technological advancement impacting the landscape of metabolic surgery in the coming years? Right now, a lot of young fellows, they want to have a robot, and they're looking for the hospitals where they have robot to go and do, join that one. I myself, being a robotic surgeon, I came to Harlem Hospital from NYU. The first question I asked them, do they have robots? So they found a robot for me within a couple of months, and we have done 400 cases so far. So what do you look in the future?
Very lucky boy.
Let Dr. Fielding answer this.
So basically, it's the same at NYU. It's the same at the main campus at NYU. Our bariatric group there tries to do essentially everything robotically, and that includes the gallbladders and the hernias and everything else. So the first step these days in our practice is robotic.
I just want to, regarding this subject, I just came from overseas operating. I mean, we are talking about robotics and technology, and we always tend to forget that the rest of the world, you can hardly get a suture material. There is no stapler, there is no ligature, there is no clip applier, and this is the real world out there. So while we spend our time here focusing on whether we're getting the latest gadget, if you want, quite honestly, we're missing what's happening around the world, unfortunately. That's my only comment in this regard.
But I also think you're missing the opportunity of showing that robots may not be as beneficial to the patient as they are to the surgeon, because I think there's accumulating data that surgeons have less back problems and a variety of other problems being able to use the robot instead of even minimally invasive surgery.
No question about it, Dr. Newman, no question about it. Every level of evidence paper has been, at best, not even showing equivalence, but this is a separate discussion.
Yeah. The other thing is, what about the peroral approach? Because that also would have great applicability in low resource countries. What do you think about the development of the endoscopic gastric procedures?
Again, I'll let Dr. Fielding take the question here. For bariatric or for other procedures, your question?
Pardon?
Yeah.
No, there's no doubt this is a developing field, and it's going to have, some benefits for sure. It's still very little. I think it's little understood still. It hasn't got the track record that the other operations have, but it's definitely part of the future landscape. There's no doubt about it.
That's the last question before we move. Nowadays, we started with the gastric bypass. In fact, the gastric band came up. Now, sleeve has become the most common operation in this country as well as worldwide. Like 70% people want gastric sleeve right now. And the other new operation is coming up, like single anastomosis, videoileostomy, which could studies, duodenal switch, one anastomosis gastric bypass. I have not done it because my patients are not very educated in terms of the post-op care. How do you foresee goes to Dr. George Fielding and George Fursley about offering this type of operations, which is more metabolic to patients who are not very educated? Who can their IQ levels, most of them are not very good, and they don't understand what operation they can go through. And I have seen people, surgeons, and exposing and doing these operations, and patients not understanding how to manage them post-operatively. What are your thoughts and advices to us?
So I think if you offer OAGPs or duodenal switches, any of these operations, which we've done for a long time, but if you offer them to patients that either can't afford the supplements they take afterwards or don't understand the importance of taking the supplements. You will get a lot of sick, serious vitamin deficiency.
I mean, quite honestly, having lived in the area of gastric surgery and ulcers and gastrectomies, and I mean, this is where gastric bypass in 1954 became an operation for hyperlipidemia. And for quite honestly, my generation at least, if you don't need to come next to the duodenum, stay away from the duodenum, especially if you operate and you're going to see your patient for the next 20, 25 years, or 15 years in the same community. Just that's a word of caution. I will not elaborate more.
Yeah.
So
You
thank you.
don't need to repeat history, right?
Exactly.
So thank you very much for your time, ladies
All
and
right. Nice to see you all. Thanks a lot.
Thank you. Thank you very much.
Thank you.
Good evening.
Thank you.
thank you, Miss. So as we come to the close of this enlightening grand round sessions, I would like to extend my heartfelt thanks to everyone who participated and contributed to today's discussion on the surgical management of morbid obesity, personal experience and outcomes. First and the foremost, I would like to express our deepest gratitude to Dr. Patricia Newman for her outstanding and insightful presentations, and also like to extend my sincere thanks to our esteemed panelists, Dr. George Fursley and Dr. George Firling, for the expertise in minimally invasive surgery and have shed new light on the advancement in bariatric surgery. We hope that the knowledge and ideas shared today will continue to resonate with you all and positively impact your professional practices. For this, have a very wonderful evening, and we look forward to seeing you in the future grand round sessions. Thank you very much.